We know that people are busy and out and about and on vacations and taking care of all kinds of, fun family activities. And so really appreciate each of you taking time away from that. And so I'm Bob Rowe. I'm the president of the Academy of Orthopedic Physical Therapy, and I'm happy to facilitate and moderate this meeting tonight of our virtual town hall. And tonight our title is how AOPT is fighting payment cuts. And just so that you know, for the future, we're based on our strategic plan. We have 4 drivers, and for each virtual town hall, we're going to present a subtopic from each of our 4 drivers. And so tonight is from our driver related to payment. And so we're going to dig into payment strategies. And I'm really fortunate to have such a great panel with us tonight. We have 3 of our experts here, and I'm going to go ahead and introduce them. Marcia Spoto is the chair of the AOPT Payment and Value Workgroup and one of our representatives to the Payment Consortium. She is professor emeritus of physical therapy at Nazareth College in Rochester, New York, and dual licensed as a physical therapist and chiropractor, and is ABBTS board certified specialist in orthopedics. She's currently an adjunct faculty member at the University of Pittsburgh in the primary spine practitioner program, and chair of the APTA New York Public Policy Committee, and consultant for the Exelis Blue Cross and Blue Shield in Rochester, New York, as well as for the Spine Care Partners. So thank you, Marcia, for being with us. We also have Matt Hyland, who's the chair of our AOPT practice committee, and another one of our representatives to the practice consortium, which you guys will hear more about in a little bit. He's a past president of APTA New York and served as the APTA board member from 2014 and served as an APTA board member from 2014 to 2021, including serving 3 years as APTA vice president. While on the APTA board, Matt served on PPAC for multiple years with 3 years as the chair. So we appreciate the expertise that Matt brings with his PPAC experience. And then last but not least is Bob Hall. Bob Hall is the payment consultant for the Payment Consortium, which is the collaboration between the AOPT, APTA private practice, and APTA. Bob has helped health professionals maximize their collective impact for more than 2 decades in Washington, D.C. He is currently the executive chair of Sabre Advocacy and has also served as the director of government relations of the American Academy of Family Physicians, the Access to Care lobbyist for the American Academy of Pediatrics, counsel to U.S. Senator Mark Dayton, attorney advisor to the U.S. Securities and Exchange Commission, and chief clerk to the Texas House of Representatives Insurance Committee. He holds a master's in public affairs and the LBJ School of Public Affairs, a Juris Doctorate from the University of Texas School of Law, and a BA from Haverford College. So a very impressive panel who all have tremendous depth and breadth of experience within payment, and so excited to have them here. And they're going to provide some presentation, and then really the hopefully a big part of this will be an opportunity for you guys to have a conversation with them. So without any further ado, we'll move forward, and Marcia, you're up first with and I'll move the slides for you. Just let me know when you want me to move the slides.
Yeah. Okay. Thanks, Bob. And I just first like to really applaud the Academy for, focusing this spotlight on payment and developing a strategic plan, and really putting the structure behind this to allow this to happen, and especially under Bob's leadership. So, and I did want to just introduce the Payment and Value Workgroup that I'm currently chairing. And I wanted to give a shout out to the membership here. So you see all the members. We started our work, I think it was really the beginning of 2021 where we really started our work. And our charge was it was pretty broad. The charge was to enhance payment through demonstrating our value. So that was our charge. So yeah, Bob, if you want to advance the slide. So I just thought I'd highlight some of the things that we've worked on over the past several years. We, one of our first, I think that the thrust initially was to really collaborate with PPS. And a couple of our members were dual membership in both sections. And so we had immediate access to communications with PPS, and we really wanted to streamline our work. And, kind of a major theme of what we're doing is just trying to coordinate better within the broader umbrella of APTA. But our two sections are certainly most active in this realm. So one of the things that we did early on in March, we collaborated with PPS on hosting a webinar on how to appeals claims denials, which was very, very practical information. That was definitely a little bit in the weeds, but it was great. One of the members of our committee, Gwen Simons, who is also a lawyer and is the, I believe, the lobbyist for Maine chapter. She hosted that, and she did an excellent job. Very, very, important information. We also surveyed the membership on payment and administrative burden. And, one of the challenges I think that, I'll just mention is that we have, my background is in private practice. I owned a private practice for about 40 years. I'm dating myself here, but we have members in all different practice settings, and some have more direct access to, administrative decision making, for example, than others. So it's creates a challenge. But we did get a really good, I think, sense of where our membership was, and some of the challenges they were facing. I realized afterwards that this wasn't CMS. This was supposed to be CSM. So many acronyms with CMS, you have to have a PhD to understand them all. But we host, actually AOPT sponsored a group of us that presented on a topic of addressing the value conundrum in physical therapy. Because again, I think, our goal is to enhance payment, because I think there is this just broader sense that we've been undervalued in the healthcare system. So, how do we really get past this value conundrum? And that was, I think, well received. We've added some payment resources on the website. And we are also working with Bob Hall on commenting on the Medicare physician fee schedules that are coming out. Of course, the 2025 schedule was just released, and I know we're going to be talking about that later, and other proposed rules. And we also have collaborated with APTA on especially input on the quality measures that are being utilized in the MSK MIPS value pathway and the related low back pain cost measure through CMS. So those are just some of the things we've worked on. All along too, and if you want to advance, Bob, my last slide here, I just wanted to, kind of, talk a little bit about some of the general principles and some of the things we've learned, over the course of the past few years. One is that there is no single definition of value, certainly as it pertains to services provided by physical therapists. I mean, it really depends on, who the stakeholder group is. And the idea is to address the problems that the stakeholder group has, and really try to align incentives and meet them where they are, and particularly with on the payer side. We have struggled a lot, I think, to become involved in value-based care payment models. Our profession has lagged behind other professions there. And that's because I believe that a lot of the structural aspects of our healthcare system, not the least of which is, the development of ACOs back when during healthcare reform, and we were largely left out of those ACO structures where a lot of those value-based contracting decisions are made. So I've already really talked about the importance of our collaboration and coordination, and there's, again, I just been very, very pleased to see, how much things have come together. We're integrating a lot of our work with PPS now. It's actually just, there's been this general trend toward greater and greater integration. Payment is not, cannot be addressed in isolation. So the legislative side is really important. And, we're really both within the AOPT and also with our collaboration with PPS, we're really, integrating those two things, as you will see when we get into talking about some of the accomplishments here with the Payment Consortium in particular. This is my own personal thing, but I just really believe that payment reform has to work in parallel with changes to the musculoskeletal clinical care pathway. And I think we all know that our value is demonstrated, most when we are frontline providers. So however you want to designate that, the fact that we're becoming increasingly frontline providers in the system. And then, with commercial payers in particular, that's been a more difficult challenge, I think, for APTA. A lot of the focus with APTA has been on, the federal side necessarily. That is so complex, and they've done great work with, particularly with CMS. Commercial payers, it's just more challenging. There are, of course, national players, and then there's a lot of regional players. And there are multi-state players, and then there are just, really local players. So it's a lot to get your arms around. But we've really talked a lot, particularly within the Payment Consortium, about being more strategic and helping the membership become more strategic in contract negotiations. And they will be coming out. The Payment Consortium will be producing, more information, more resources in that regard. For the future. So look for that. And then I think this goes without saying that membership engagement and advocacy is really, essential to our work. And I know Bob Hall will speak a little bit more about this too, but, we have such physical therapists are just so, they're so willing to provide their time to devote to advocacy. And but yeah, so I just, I think we've come a long way over the past 3 years, and I think we're excited about the future. So thanks, Bob.
Thank you so much, Marcia. Appreciate all that information. That's great. I'm going to move on to Matt Hyland.
Yeah, thank you, Bob, and thank you, Marcia. Welcome, everybody. As many of you know, physical therapists are being paid significantly less today than they were 10 years ago, and there's continued cuts proposed for 2025, almost 2.8% decrease in payment. The threshold for payment is going to go up to 2410, which is just like. Did you skip ahead 2 slides, Bob?
Did I or can I?
Can you go back? Go back one more. Yeah, I think we're missing a slide, but that's okay.
Okay. Sorry.
So go ahead one. Thank you. I apologize. Yeah, and so there was a slide that I was going to have in there that talked a little bit about comparing rates from 2014 to 2024 for Medicare. Under Medicare, looking at CPT codes, and that decade is started the year after MPPR. And when most insurances come into any states, they look at two identifiers, workers' compensation and Medicare. And in many states, Medicare is the lower paying of those two. So private payers settle in around the lower of the two payers, which this case would be Medicare, which makes it very difficult to try to increase pay rates when payments gone down for the better part of the last decade. And then as we move to this slide, it talks about the 2.8% decrease for 2025. That's in the proposed fee schedule. And the only way we're really going to make a change to that is through advocating Congress to intervene to try to change those rates. The therapy thresholds in 2014 currently is $2,410 for, I'm sorry, 2330. In 2024, the proposal is to go up 2410 in 2025, again, combined with speech. The targeted medical review maintains at $3,000, and it's going to stay there until 2027. It was a 10-year rate, and at which time in 2027, moving into 2028, it'll increase annually by the medical economic index. A big win, and it's easy to complain about payment, but for those of you, in private practice, treating patients every day, owning practices, the supervision requirements that were so outdated and antiquated for outpatient physical therapy, that PT had to be direct supervision. That's proposed to be removed to general supervision, which is consistent with other areas of practice. The one kind of caveat to that is to make sure your State Practice Act allows for it, because even if CMS allows for general supervision, but your State Practice Act says direct supervision, you have to follow your state law, even though it's more restrictive than the federal law. And the Plan of Care certification is another nice win in this case, that if you do receive a referral from an MD or another non-physician certified caregiver, that you don't have to send the plan of care back to the physician to have them sign it. And you just have to make sure that you have identified that in the patient's medical record that you have the prescription or the plan of care from the physician, and you have to, in that you've sent your evaluation, including the plan of care, to the physician within 30 days. You can advance a slide, Bob. Thank you. Some other positive advocacy wins, if they go into the final rule, is that for the calendar year 2024, CMS approved payment for caregiver training. And in 2025, they've increased that, created more clarity around it, and also, how a caregiver training can be given and billed for. Telehealth is a bit of a frustration. The temporary flexibility that we received through COVID that allowed us to provide our care through various platforms of telehealth is set to expire at the end of this year. And CMS has made a decision not to extend that beyond the end of this year into 2025. So a bit setback. However, again, as we continue to lobby and advocate for really many of the health professions that aren't able to receive payment moving forward in telehealth, we continue to lobby Congress to try to make changes to extend this to more permanency and not just through the COVID package that we're still working under. Some MIPS changes. There's no substantial change really to the policies in the proposed rule. There are some proposals that would mitigate the impact of accidental submissions, which is currently a problem. Specifically on weighting changes, CMS is proposing to allow clinicians to request reweighting of quality promoting interoperability and improvement in activity categories. And not much more to say about that. And then in the last bullet, last year, CMS introduced rehabilitative support for musculoskeletal care, MVP, the first MIPS value pathway that PTs could actually participate in. For 2025, they're proposing 5 new quality be added to the MVP, 1 improved activity added, and 2 improved activities removed. And I think we'll probably take questions at the end, so I'll turn it back over to Bob.
Thank you so much, Matt. Appreciate that. And we'll move on to Bob Hall.
Great. Thank you all so much. And I'm very lucky to be here. I feel blessed to be with y'all. So I know that we talked about this last year, and it just feels like payment is getting worse, right? There is a yearly cut from Medicare that requires us to go through this dance with Congress to blunt the cut every single year. So it's advocacy upon advocacy upon advocacy. The other thing that I think we generally face is, just the fact that private rates are often based off of a percentage of Medicare rates. And so if Medicare cuts payment rates, which is really Congress cutting payment rates, then CMS implements in the weeds. Generally, the way it works is, Congress passes the skeleton and the federal agencies put on the flesh on the body. If Congress doesn't sort of blunt those cuts or decrease the payment damage, it then bleeds down into private sector payments. And generally that private sector payment, we all know the big, largest insurance companies, but oftentimes that private sector payment can be impacted by state level advocacy. So if you're dealing with, the Uniteds of the world, the Blue Cross Blue Shield, Cigna, Aetna, Humana, those large payers generally are going to have state level advocacy, or state level advocacy is going to impact them. And it can actually have a real impact, not only on your practice, but practices throughout the state. And what we decided to do in dealing with the payment consortium is to focus on two areas that we know APTA does a good job with, but that we can help support. And so really that is state private payer advocacy. So, those big five that I mentioned are going to have state plans like I'd stated, but we're not talking about advocacy with the state legislature. We're talking about individual or chapter level advocacy with those payers. So hopefully pay chairs in each of your states are having frequent meetings with those payers to bring concerns from the memberships in those areas about payment policies, utilization management, other administrative burdens. Generally, we can't negotiate rates directly. That's actually normally in the view of antitrust laws forbidden. And so what we can do, though, is we can help practices negotiate more effectively. And so that really impresses upon us the need to move forward with getting folks more comfortable with negotiating and recognizing they even can as a threshold question. And then finally, the thing that we think would be wonderful if we could have a real impact on something that is a state regulated plan, essentially, generally in another area of the state government, is Medicaid. Right? Many private practices and others find it very difficult to afford to help with Medicaid, to see Medicaid patients. When I was working for pediatricians, there were so many kids on Medicaid, but the family docs, generally, they would just take Medicaid and write it off because the payment rates were so bad and the administrative burden was so high. If we made Medicaid pay better, if we decreased the utilization management, administrative burden, et cetera, that folks experience with Medicaid, it could be a functional payer that folks could really benefit from in their practices, and then benefit individuals in their communities who really need PT services, generally very sick populations, low income, folks who could really be healthier as a result of PT interventions. So we know that payment is getting worse. I don't think that's a question. What really needs to happen then is what we do about it. And that really does require coordination. And that's what these next few slides are really about. So if you go forward, please, Bob. Thanks. I think this may have been the slide that Matt meant, and I apologize that it wasn't in that order. This is sort of a more general conclusion that, look, Medicare is the one that sets the stage, and then we know that over 10 years, the majority of codes really have seen decreases over 10 years. This is while at the same time everyone is concerned and impacted by inflation, and then this doesn't even include MPPR or the PTA cut. Right, so it's worse than what this slide shows. You guys know it on the ground. You know that it's very hard to address, some of the bottom line issues in practices. And so, what do we do, right? And this is the last bullet. Medicare often reverberates to private contracts because those contracts often refer to percentages of Medicare. If we'll go to the next slide, please. So, PPS and the APTA private practice these days, recognized this was going on and really reached out to AOPT, and Bob, took up the standard, heard the call, and call from members as well that, um, in surveys for AOPT membership, right, this was a very high priority for AOPT to try to address. So the payment consortium is at least a start of an answer to the payment cuts that folks are experiencing. We do want to try to see those payment cuts blunted, and maybe even see a raise one day would be kind of nice, as opposed to having to take more volume to try to make the bottom line. What's great about AOPT is you guys are the largest component of APTA. And so, while APTA is absolutely the mothership, in my mind, they're very much like the American Medical Association. There are all of the sections, chapters, et cetera, components that are part of the APTA, and y'all really are in a driver's seat in terms of membership to be able to move both APTA and independently advocate, as well as support chapters and really bring information to APTA staff. And prioritize their focuses and then fill in some gaps for them as well. So APTA private practice obviously already focused very much on payment. There's been many years of Medicare fee schedule comments. That's often seen as the sort of standard by which you're measured if you're really engaging in payment advocacy. And this year's no different. We will be meeting with APTA staff probably for the third time to discuss our payment, our fee schedule comment in the next week or so. And what's great about that is we're really integrating some of the work that AOPT is doing. Marcia's group is likely going to meet with some APTA staff to talk about the value-based structures in the fee schedule, including MIPS and MVPs, the sort of next evolution of MIPS. And so we'll try to tell them, inform them what it's like for folks in orthopedic physical therapy to try to help them understand how difficult it is to make MIPS work and what are some of the pitfalls as we try to implement the next evolution of it in MVPs. So we are trying to, create access to appropriate PT care for all. That's far off, I believe, sadly, but we have had 6 meetings at this point, and we really developed some pretty far-reaching goals that we're going to try to reach by the end of this year and over the next. So why don't I try to go over a couple of those goals? They're really in those 3 areas that I'd mentioned. And let's see if I can pull them up. Yeah, so in terms of decreasing administrative burden, right? One of the things that we recognize is that this feels like it's a very difficult thing to advocate on because it's policies, right? That how do those policies get implemented at the state level and by different payers within that state. So we do think that you guys need more resources, right, on how to deal with prior authorization. We have some really good resources already on the State Payer Advocacy Resource Center, but the problem is that they need to be actionable. And so we need to be providing more information to you. We're also hoping to establish an advisory support task force to assist. We also want to focus on some other things that we believe are impacting access to services, which are fair copay resources. APTA already has some really great advocacy, and chapters have great advocacy on trying to address the issue that sometimes PTs are treated like specialists and specialist physicians in terms of the copays that their insurance imposes on them. My bias is that you guys shouldn't even be treated like primary care in terms of the way that copays are paid out. That's oftentimes the target that folks search for is, hey, treat us like primary care. The problem with that approach is that, how many times a year do you see your primary care doctor? It's probably on average 1, right? Whereas for PT, you might be going 12 times before there's even a request for prior authorization. So it's a $50, pop for that primary care visit. And it's $600 just to get the plan of care that you're recommended before prior authorization. That's really prohibitive for folks who are on private insurance but might have low incomes. Large families with lots of copays that are really high. It can become cost prohibitive to access the services that are medically necessary for those family members. So dealing with fair copays is another important advocacy priority. And we want to stand up a learning network for the delivery of resources and sharing of best practices with chapters. A private payer Medicare credentialing initiative is another thing that the APTA is pushing forward. We're hoping to decrease the amount of time you guys are sitting on new employees who can't bill as a result of the insurance company not actually providing credentialing. and taking in some instances 180 days or longer while you're paying out a salary. It's very, very difficult to hire new folks, not only because they can't have a salary that lets them then pay off their student loans, but because, at least initially, it's very difficult when the insurance company won't even credential them to be able to bill. In fact, you can't, it's illegal. And so we're very hopeful also that we increase the opportunity for folks to be able to bill off of the work that those new hires can do in those practices. We're also excited to try to work on the clinical practice guidelines and make them a little different, or not different, but translate them essentially to something that's actionable for insurance companies, and then push that forward in some of these new payment models that Marcia was speaking about. We actually want to continue to direct negotiation with the big five payers at the APTA level. We've had longstanding meetings with United and Cigna, some of their utilization management vertically integrated groups, including AIM and others that aren't really doing the best job, I would argue. And so we need to be pushing on them to try to improve and allowing folks to actually get the services that are medically necessary that might be in the plan of care but are being precluded because of really outrageous prior authorization requirements. And then we do want to try to deliver a consensus statement on prior authorization and utilization management. In terms of improving commercial payment, that second bullet on the bottom there, we want to investigate best payer payment benchmark databases. We want to try to figure out what payment is going on in the real world, not in a way to create collusion, but we do know that we don't have a full picture of how it's working in different states and what those payment rates are. So if you aggregate it and de-identify it, that's legal. And so we're hoping to be able to work with some current databases or figure out some other information that can be actionable for us. We know that there's huge regional variation as well, which in my mind makes no sense, but can depend on local economies, and we don't want sort of uniform payment, but we do want an understanding of what payment variation there is in different markets. We want to establish joint operating committee resources and an advisory support task force for commercial payment as well. We want to do that same thing with the private payer Medicare credentialing initiative, and basically educate and inform PTs how to negotiate more effectively. I had a PT call me up who was actually in a mentoring group and somehow found her way to me. And had never negotiated or even reached out to her payers in the past, just saw her payments static for year upon year upon year, was a solo practitioner. And so I gave her some resources, helped her try to get some bullet points together, talking points. She called up all of her payers, and one payer immediately raised her rates by 5%. She'd just never tried before. Right. And so I think we need to get out the good word that this is doable, that it's possible even for a very small practice to be able to pull this off. And we are here to support that advocacy and that work. Folks just don't believe they can do it. And so we need to shatter that assumption and that perspective, because it's really not true. This can be successful if you go into those negotiations and can get the negotiation set up based on some strategies we're going to try to educate folks about. And then finally, on Medicaid, like I said, this population is who we should be providing services to, right? It is an equity issue in the United States that there are so many folks on Medicaid who really don't have access to care if they have that Medicaid card. So if we were successful at making Medicaid more pay better, as well as decrease administrative burden, we could really be doing a good service for folks in our communities who need this care. And so we want to work with the pediatric section on access to appropriate state legislation to help folks get those services. We want to also understand network adequacy requirements that are there as a result of Medicaid law. There's a new Medicaid regulation that went into effect that CMS put out last year that AOPT commented upon. And essentially what it requires is that payers have to report on a biannual basis to CMS what access issues look like. It doesn't drill down as far as PT, but we can encourage payers, and we have, to produce that information voluntarily, as well as interact with CMS to get them to encourage states to try to get that information. Most of the people who are coming onto Medicaid now, especially in expansion states, are managed care, are covered by managed care companies. And so, we see that as really the way to help these populations is to try to regulate those managed care companies, which do have network adequacy requirements. Otherwise, the state would be unable to contract with them. Unfortunately, much of the time, that information isn't very public and it's not very available. But the states, because they are paying them, they have federal requirements to meet network adequacy now and report this information. We're encouraging the inclusion of PT in that reporting. We also have seen some states, in fact, in Arkansas, there's someone on the payment consortium who was able to work with his state to get Medicaid to actually pay more than 100% of Medicare. And so we are having, good successes out there, but folks generally don't know about them. So we do want to try to encourage that sharing of information from group to group. And hopefully we'll see more success stories like that. We're really trying to get at least half the states above 90% of Medicare in their Medicaid payment. Good luck to us. I think it's going to be very interesting and challenging, but we are hopefully going to be moving forward with some of that work. So the other thing that I'll just highlight is Bob Rowe and Mike Horsfield, the president of APTA Private Practice, were able to talk to the exact right population of pay chairs and others at the State Payment Forum in Kansas City just a week ago. So this is very up-to-date information, very timely, and we had really good feedback from folks. They said they said they felt, at least one person said that she felt like she was on fire and couldn't wait to go and do this advocacy in her state. We're very hopeful more folks start feeling that spark and get them sort of moving on some of this advocacy to improve payment in their state. So that was a lot of time on one slide, Bob. Sorry, you'll go to the next one, please. All right, so speaking of sparks, this is the State Payment Advocacy Resource Center, which is an APTA and AOPT and APTA Private Practice resource. It is something that has a lot of information, a lot of resources for folks. One of the things I wanted to highlight is how you get there. Right, if you go to APTA's private practice section website, you'll find this link. And if you, Bob, I think you can click and hopefully something animates. If you just click the mouse, and then hopefully there we go. That's what you click in order to get to the Spark initially. And then there's one more click, I think, that's on this slide as well. If you click once more, Bob, there we go. This is what I wanted to highlight was the model contract language. When I came here, and it's been almost 5 years at this point, one of the resources that I just thought was excellent, but can look a little intimidating. And if you click again, Bob, I think there's 2 more animations. Yeah, there we go. That key checklist for managed care provider agreements, what my hope is I think it's 17 pages long, so it looks crazily complicated, but it's really not. Again, back to the point that you can negotiate contracts. What this resource provides is a side-by-side of what you ought to be looking for in terms of payment terms that are friendly to you, payment terms that are friendly to the payer, and then what some of the common provisions look like. So we want you to be going for the third column here, the provider-friendly provisions. And what folks I think oftentimes don't realize is that contracts are not just about the payment rate. They're about a whole bunch of other components of how that payer interacts with your practice. And they're going to try to put in all of the most onus contract provisions that they possibly can, this far right column. That's what you want to be trying to negotiate against. And you can do it. Contract terms are malleable. It's a contract between you and the payer, and there's oftentimes some flexibility within the payer to modify those terms. Folks in those payment offices actually do have some opportunity to modify things, especially if they're going to make it very difficult for you to provide care in those communities, and if they can't get the network adequacy they need to adequately provide access to PT services. So that's one resource I'd really like to highlight. In the contract language, we also have a webinar on how to negotiate better payment rates and multiple articles. If you go to the next slide, please, Bob. And I think this has some innovations as well. Again, these are some of the other areas that we focus on the State Payer Advocacy Resource Center. Utilization management and prior authorization. One thing that folks don't recognize that they can do is, I'm assuming that most folks have received a denial letter back from a payment back from a payer, saying that, you know, this doesn't fit within our structure, it's not medically necessary, et cetera. We've done this review, and, you know, after the peer-to-peer or whatever, we still don't think this person should get these services. Those can be appealed, right? And they are required under the Affordable Care Act to send a letter saying, hey, if you want to appeal, you can do this. And then if you go ahead and take on that appeal, a lot of the times they'll just deny you again, right? They've already done their analysis with the prior authorization. They said, yeah, we didn't prior authorize it, so why are you appealing now? Well, the appeal is your right. It's the patient's right as well. And you can stand in the shoes of the patient much of the time. If that appeal then gets denied, so you've seen your prior authorization, you've done your appeal, you still have a third level of review that you can go to, which is an external review. And what's really unusual about this is almost nobody does it. And so it raises attention for payers if you do it. And B, oftentimes payers have to pay out of their own pocket to the external review organization to take a look at the appeal that they denied, right? So it is absolutely a little bit of work on the part of the PT and the PT practice. But we've had one practice in particular that had, I think, 21 different clinics. They just assigned an admin to appeal every single denial over and over and over again, and they started really getting the attention of the payers, right? That's what you want. You want to set up a negotiation with the payers to talk not only about appeals, but to talk about payment rates and some of these other issues you're facing. You know, these workforce issues that folks are discussing, they're real, right? And they're a result of payers paying too little. If the payers paid you enough, you could pay these new employees, these folks just out of PT school, even PTAs, better. The problem is that the payers don't pay you enough, right? And in order to afford that. So really, in my bias often is that payment is the key. If payment flows adequately, you'll have a healthy practice. And there's certainly, you know, more components than that in running a healthy practice and making sure that, you know, you're in the black, but at the same time, you know, payment is often just too low. And so it's really important to understand your rights. We've also had one practice, again, in Arkansas, that just decided to appeal every single time that they got a denial. And 9 out of 10 of those appeals were approved by the external review. They got overturned, I should say, in the external review. So I just think people don't do this, and they don't know what their rights are, and it's really not that hard to do. Some other things in terms of resources that we have are title and term protection, the PTA differential, and PPR. All of those resources are available for you on the State Payment Advocacy Resource Center, or SPARC. Now, the last thing is the slide here from Bob. Hopefully, I want to give out my phone number and my email to folks. I really am here to help you. This is what the Payment Consortium is also doing, is we recognize this is a very atomized, you know, knife fight in the telephone booth in most practices, right? It's certainly not a fun thing to go through, but we are here to help you. I am here to help you. APTA staff are here to help you. They do such a good job. I can't say enough good things about APTA staff and how collaborative and supportive they've been. They want to help you have a healthy practice, and as a result, you know, find the joy in providing physical therapy. Too much of it is focused on paperwork at this point and gunk. It has nothing to do with actually helping people in terms of the way that the payer burden, the burden that payers create. So we want to try to get rid of that, clean that out. Help you all enjoy your practices again. We know that payment rates are too low often to allow for that. Administrative burden is too high. And geez, if we could get more Medicaid folks actually in your doors because payment rates are good enough, or, you know, and or the utilization management and prior authorization administrative burden is low, you could be providing even more services within your community. So sorry to go on for so long, but it is a complicated area, and we really are, AOPT really is supporting a whole bunch of action in this area. So happy to answer questions, or Bob, if you want to go to the next slide. I think that's all I have to say. That's sort of structured already.
So thank you so much to Bob Hall, and thank you to our entire panel. And right now, we have about 15 minutes or so to open it up to the group to ask questions or provide comments. So let's. I'm going to stop sharing my screen here, and so we can. So if I'm looking for the, and I don't see it, a place to raise your hand. I don't, why do we not have all the features here, staff? Um, I don't know if it's just me.
Bob, they're actually shown under the reactions
Okay.
option.
Yeah, but they're not, I mean, it's only showing up as recognize hand gestures. I mean, again, maybe that's just mine, but it's not, there's nothing there really there. It's not the normal suite of opportunities to raise a hand or react or whatever. All right, well, Anthony figured it out. So Anthony, you're in the queue, so you're up.
It's actually, if you hit the react button, it pops up and then you can pick a raised hand.
Oh, okay, so it's not this little arrow to the side, it's, you just hit the react button. Gotcha.
Yeah.
The little
So
heart.
anyway, Bob, I'm kind of interested in what you were talking about, and I can't remember exactly what you were saying in terms of the committee to help people along with utilizing some of the tools that we have provided for them. I think one of the things that people are afraid to talk to big payers. They typically have all the cards, and typically, at least in the Cleveland area, we kind of get pushed around. And there's been several times where I've emailed a payer and they basically emailed me back and said, no, we're going to keep our rates the same. And that, so we can provide something about dues or something like that. And then that's the last I ever heard from him. I kept emailing him and I couldn't get in touch with him anymore. So I don't know if you can help me explain that little committee again or whatever.
Sure. So there's joint operating committees that have been successful in some states that help folks share contact information, share, folks who are friendly within insurance companies, or as friendly as they can be, I guess, things that have been successful for them. And so one thing that we can do, though, is APTA is incredibly generous in providing us the opportunity to work with their resource that actually has a web service that crawls the web and finds contact information for folks who work within payment, within insurers. And so I'm happy to look that up. APTA, again, has been incredibly generous in allowing us to do that. And if you contact me, I can, find the CEO and a few other folks, within the organization. You don't want to talk to the CEO most likely, but you do want to have somebody pay attention to you. And so, if you write a quick letter, which I can also help ghostwrite for you, saying, look, we've contacted you 5 times over the last 6 months or 5 years or whatever, and no one's responding, hopefully that can get some attention. And then the other thing you can do is you can CC the state insurance commissioner on that letter and, start getting the state regulatory agency involved. The other thing that we can do is we can start compiling some of this information and really, walk with you on this. There are federal oversight agencies, the Office of Consumer Information and Insurance Oversight, for instance, which was created by the ACA, that is there to deal with Obamacare plans or plans that list on the exchange. If there are complaints about those plans, the feds want to know about it. And certainly on the Medicaid side, there's a huge federal component of payment that goes to the states that then contract with the managed care companies. So here in DC, which is unfortunately my bias because I'm sort of a creature of this town, you really can move the needle a little bit with some of those federally funded payment structures. So there are options. It can feel like hitting your head against the wall, but especially if you provide data, what payers often say is they don't have enough data to help make decisions. So, the kind of information that Patricia put into the chat about how expensive it is to try to hire staff, I think it is the perfect time to go out and negotiate with these payers saying workforce is such an issue because of you, right? The payers are not paying enough for you to afford an adequate workforce and therefore allow them to have network adequacy. So, they're feeling the heat a lot in the administrative burden and utilization management area, especially in Medicare Advantage. There's new rules that are going to go into effect, federal rules that will go into effect in 2025. And they're gearing up for some of that. The other thing that we're very hopeful is that one of the other things that AOPT commented upon in the administrative burden area is that right now, on average, the information shows, I think this is Employee Benefits Research Institute, that the average prior authorization takes about 11 minutes to adjudicate. And there's going to be a new regulation that goes into effect in 2026 that requires electronic data exchange. So like HL7 stuff and fire and, you know, all these sort of in the weeds coding rules. Those will go into effect in 2026. And basically, because so much of the prior authorization will become supposedly, you know, electronicized, and I'm sure they'll be using AI and other structures to help make that move more quickly. I hope it will. They say that, you know, from the average of 11 minutes for prior authorization adjudication, it's going to go down to about 3 minutes once all of those structures are set up. That's CMS's assumption. I think we're going to have to ride them and make sure that they get the Medicare Advantage plans and actually all other plans who use any sort of payment, electronic interchange of information for payment to implement all of those changes. So there will be changes coming. It's a result of some federal regulation, but we're going to have to make sure that, again, your rights are defended and folks even know what those rights are.
Thank you for the question, Anthony. Thanks, Bob, for that response. The queue's open. There was a question in the chat, but the individuals left, so I don't. Anything else? This is your moment with all these experts here to get that answer or make a statement. All right. Well, I don't want to drag it out, and so it's been such an incredibly informative evening. Once again, thank you to our great panel, Marsha Spoto, Matt Hyland, and Bob Hall. You guys were provided such fantastic information. We're so thankful and appreciative to have your expertise working for us on a regular basis, and you know, this is something that they're doing all the time, you know, and I'll point out that Anthony is chair of the AOPT Administrative Burden Work Group, so he's you know, right in the middle of this whole thing too. I don't think I saw anybody else you know, from the work groups on the call here, but there's lots and lots of people within AOPT staff, board, so many people on the AOPT work groups focused on payment, and then the of course the payment consortium is a huge opportunity for us to really make a significant difference in payment, and we're really only in our infancy, and we're already seeing so many significant benefits and value of our impact of what's happening. So we're really excited. Oh, and I'm sorry, Jenny Haggis is also here, who's a member of that work group. So anyway, look, thanks. Hope you guys have a great rest of summer, and we'll be announcing soon the next virtual town hall, and hope to see all of you then. Thank you very much. Take care. Have a great evening.
Thanks, y'all. Thank you.
Yep.
Thank you so
Bye-bye.
much.
Thank you.